Well, hello there, and welcome to this session, Getting to Net Zero Healthcare for All, Standardized Metrics, Mitigation, Access, and Quality. I'm Dr. Sherman. I'm Associate Professor and Director of the Yale Center on Climate Change and Health's Program on Healthcare Environmental Sustainability. I will be moderating today's session. By way of background, the healthcare industry is responsible for nearly 5% of worldwide greenhouse gas emissions and similar fractions of toxic air pollutants alone. These emissions arise directly from healthcare facilities and indirectly from the supply chain of healthcare goods and services. Healthcare pollution harms public health, yet it remains underappreciated and largely unaddressed, despite our duty to first do no harm. While healthcare organizations are large polluters, they are also the frontline responders to the health impacts of extreme weather and other environmental damages. Health systems must mitigate emissions, adapt, and build resilience to a changing climate and pandemics alike. This panel presentation and discussion will cover healthcare sector greenhouse gas accounting and limitations, mitigation and resilience strategies for healthcare systems, and an action plan for providers to deliver low carbon, quality, equitable care. Our first speaker is Dr. Marina Romanello. She is Research Director at the Lancet Countdown, a collaborative of more than 40 universities across the globe, tracking the relationship between health and climate change across 5 key domains and over 40 indicators. She is first author of the 2021 report of the Lancet Countdown on Health and Climate Change, Code Red for a Healthy Future. Without further ado, Dr. Romanello.
Thank you so much, Jodi, and thank you everyone for being here. It's really exciting to be, at least virtually, at COP, and I'm looking forward to joining you actually tomorrow. Jodi, can you let me know whether you see my screen? Is it showing?
Okay.
Perfect. Awesome. So I'm going to tell you a bit about the work that the Lancet Countdown does, and particularly how our research and our data offer very compelling arguments towards why the health system should decarbonize, and above everything, why that would be a really, really good intervention for public health and could help improve the health and well-being for people around the world. So the Lancet Countdown, as Jodi said, is a big research collaboration. We nucleate over 43 academic institutions from around the world. These are lead academic institutions, lead universities, but also UN agencies. And once a year, we publish a report in the medical journal, The Lancet, one of the most prestigious journals in the world. And in this report, we offer over 44 indicators that offer standardized metrics tracking the health impacts of climate change on health, and particularly what are the health opportunities and the benefits of the transition to a low carbon system. Through these indicators, we offer standardized metrics that can offer ways of comparing different countries, different performances, and about everything, tracking our progress year on year to see how we're doing with respect to meeting the Paris Agreement, which the WHO has said is the biggest and most important public health agreement of this century. So when we think about climate change, the first thing that comes to mind is obviously the rising temperatures. One of the things that we're tracking is the extent to which people, particularly those very, very vulnerable groups, people over 65 years of age, and very young children under 1 year of age, are getting exposed to extreme heat through heat waves that are putting their health and their lives at risk. Heat waves have been called the silent killers and can really tip people over the age, particularly those with underlying health conditions. One of the things that we're seeing, as these graphics show, is that exposure to extreme heat, to heat waves, has been going up pretty dramatically since the 2010, and has been going up over the past at least kind of 30 years. This has led to year 2020 seeing over 3 billion more percentage of heat wave exposure in people over 65 years of age, and in very young children, over 600 million more percentage of heat wave exposure. So those are really worrying trends. But apart from the extreme heat exposure, obviously climate change is also changing precipitation patterns, humidity, and climate in general. And that goes hand in hand with a change in the environmental conditions that make it suitable for infectious diseases to be transmitted. And one of the things that is really worrying is that diseases like dengue, that is the leading cause of serious illness and death in some Latin American and Asian countries, and which is one of the vector-borne diseases that is most rapidly spreading around the world, is becoming increasingly suitable for transmission as a result of changes that come in temperature, in humidity, that are generated by global climate change. And as you can see here, the Americas, the Western Pacific, areas that are particularly vulnerable and with very, very high incidence of this disease, are seeing the environmental conditions become more and more apt for the transmission, putting people at risk. Today, we have an estimated 100 to 400 million infections of dengue per year, and this is increasing very rapidly. In every one of the indicators that we're tracking at the Lancet Countdown, we track hours of safe physical activity as a result of the rising temperatures, heat-related mortality, lethality of extreme weather events, marine food security, sea level rise, crop yield potential, drought, wildfire incidents. In every single one of the indicators where we track the health impacts of climate change, trends are going up. We are giving a code red for a healthy future. And as the Director General of the UN, Antonio Guterres, said, quoting our report just recently, climate change will be the defining narrative of human health. And this is what we're tracking with standardized metrics. However, as I said, tackling climate change could also be the biggest global health opportunity of the century. And this is because with this risk of climate change, what we really need is for health systems to adapt and to build resilience to be able to cope with these multi-hit scenarios and with these multidimensional impacts of climate change. So what we're calling is for health systems to increase their resilience, their preparedness, and adapt to the changing climate. However, one of the things that particularly worries us is that we're seeing that countries are not responding as fast as we would need them to. What we measure here particularly is the extent to which countries are delivering on the international health regulations, particularly the implementation of the national health adaptation frameworks that will help countries deal with health emergencies such as COVID, but also with the multi-hit scenarios and the increased health risk posed by climate change. And as you can see in this graphic, there's a very big difference between the level of implementation of the national health emergency frameworks between countries with very high human development index and the most vulnerable countries with low to medium human development index. So climate change and the way we respond to climate change is amplifying the inequities between countries of different levels of human development, which is really concerning. So strengthening health systems could not only allow us to cope better with climate change, but also help us build resilience towards all types of health risks. Now, we also need to mitigate, and that's mainly why we're all here or virtually here today. And there also we have an enormous opportunity for health if we do act together to rapidly respond and mitigate climate change. One of the key elements of fossil fuel burning is that they contribute to air pollution, and the WHO this year has made even more strict its air quality guidelines for very good reason. Exposure to PM 2.5 air pollution, the very thin and most harmful ways of air pollution, are generating 3.3 million preventable deaths per year. And the interesting thing is one third of these are coming directly from fossil fuel burning, but they also come through things like transport, they come from agriculture, the burning of waste, all activities which contribute to greenhouse gas emissions and also contribute to damaging health through air pollution. Mitigating, rapidly acting to mitigate climate change could offer a huge opportunity in terms of preventing air pollution-related deaths. And when we look at our food systems, these are also a major source of greenhouse gas emissions, particularly cattle and ruminants. What you can see here in these kind of gray areas is greenhouse gas emissions that come from cattle products, meat and dairy. And what you can see here is the deaths that are associated to excess meat consumption. Almost 1 million deaths per year, we estimate, for 2017. So shifting towards more sustainable ways of producing food, shifting away from cattle and red meat production could also offer an enormous opportunity in terms of reduced death from red meat, as well as mitigating climate change and enabling a more sustainable food system. So it's incredibly important today, when we're here at COP, that we keep in mind that tackling climate change would offer the opportunity not only to enjoy economic and environmental sustainability, but also to transition towards better health and reduce inequities. So there's a win-win situation that we really need to grasp today. And this is why perhaps we're here talking about what health systems have to do and the role of health systems in this. Climate change is, above everything, a health crisis, a health problem. And health systems as such need to respond and be at the forefront of our response to climate change, because we need to deliver health without doing harm. And as Jodi just mentioned, the healthcare sector contributes to around 9% of global greenhouse gas emissions. Through these emissions, they are contributing to the climate crisis, and they are contributing to damaging our health as a response. And not only that, we turn to health professionals because they are the ones that will show us how to live healthily, that will show us what a healthy lifestyle looks like. And as such, the healthcare professional has to lead the way in showing us how we need to transition to a low carbon system, to more active travel, to more exposure to green space, to increase urban green space, to better and healthier diets, and above all, to tackling climate change for the health of our present and future generations. So with that, I'm just going to end, and I will invite you to look at the Lancet Countdown webpage at lancetcountdown.org, where you can see these metrics and many, many others, where we try to systematically track the health dimensions of climate change. And you can look at this on a country level with higher geographical resolution and what this means for your country in particular. Thank you. And I'm going to try to stop sharing.
Thank you, Dr. Romanello, for that outstanding talk. We will take our questions at the end. We'll try and leave as much time as possible. Without further ado, our next speaker, Dr. Matt Eckelman, is Associate Professor of Civil and Environmental Engineering at Northeastern University. He's an Adjunct Associate Professor at the Yale School of Public Health and has served as Analytical Consultant for the NHS Net Zero Project. He is also co-author on the report of the Lancet Countdown on Health and Climate Change. Without further ado, Dr. Matt Eckelman.
Thank you very much, Jodi, and it's nice to be here with you all. You heard from Dr. Romanello about the Lancet Countdown's metrics and reporting around the effect of climate change on health. And at the very end, there was a slide about the effect of the healthcare system regarding its own greenhouse gas emissions. I'd like to give you a high-level view of that kind of carbon accounting, looking at carbon footprints of healthcare systems, digging down into what are the largest contributors to healthcare system emissions and how healthcare systems compare. So the NHS has been a leader in this area, doing healthcare carbon footprinting for more than a decade here. And its recent Delivering a Net Zero National Health Service report put together a nice framework looking across Scope 1, Scope 2, Scope 3 in the context of a health system. Scope 1 and Scope 2, of course, are possible to calculate based on on-site information about electricity use, information about fuel use that's burned on site. These are relatively easy to track for hospitals and other healthcare facilities. Scope 3, on the other hand, includes all goods and services purchased by healthcare systems, which can be from a large variety of sources, a large variety of locations, millions of different types of goods and services. It's very difficult to track. And in general, Scope 3 reporting by healthcare systems has lagged behind, and we haven't had as much visibility about what are the large contributors to emissions overall, looking at this big picture. So I'd like to present an analytical framework, how this is typically tracked, and some of the work we've done to compare different healthcare systems. So starting with different goods and services that are used in healthcare, we take an economic modeling approach. We can look at economic models to find out where different purchases of goods and services come from that are feeding into healthcare, and looking all the way up the supply chain where those purchases come from, all the way back to raw material extraction, basic chemicals production, the basic manufacturing building blocks of our economy. And the trick here is to count up emissions that occur at each one of these steps using a framework called environmentally extended input-output life cycle assessment. So we've employed this tool to look at different healthcare systems over time. This is some analysis for the United States, most recent work looking at the last 8 or so years of available data. And what we see first is that the trend has been in general up. There's two different countervailing trends happening here. One is that the background energy system is decarbonizing at the same time that expenditures for the healthcare system are increasing more than $3 trillion in the US currently. The other thing of note here is that Scope 1 and Scope 2 emissions, while important, aren't the majority. The majority of healthcare system emissions for the United States and for most of the other countries that we've looked at are Scope 3 emissions. And this tells us that if we want to have the healthcare sector decarbonize, we need to focus on purchased goods and services. We need to focus on using these inputs more efficiently. We also need to focus on partnerships with suppliers and decarbonization of the supply chain. You'll hear from other speakers about that. Using these tools, we can also dig into what sectors are contributing to the most. This is also a picture from the United States, and you can see food, pharmaceuticals and chemicals, transportation, other types of manufacturing of medical devices. These are all important sectors that are targets for partnerships and decarbonization. Even though, of course, we're at COP and the focus is on greenhouse gas emissions, I'd like to pick up on Dr. Romanello's important comment that there are many other types of air pollutants that are intertwined with greenhouse gas emissions. And we can use the same kind of analytical framework to count those as well. So what you're looking at here is a similar map, a contribution analysis of other types of emissions, emissions that cause cancer to humans, emissions that cause ecotoxicity to ecosystems or ozone depletion. We use the same sorts of frameworks and we can quantify the total emissions that occur as a result of all these other types of pollutants to air, water, and soil. An important metric that we try to use in this work is the impact on health. Of course, clinicians and other health professionals are focused on health metrics, rightly so. And it's important to try to translate emissions and other types of environmental impacts into metrics around health as an important communication tool. So what we've done as part of this suite of work is to quantify the disability adjusted life years, the health damages associated with both greenhouse gases and the non-greenhouse gases, the other types of air, water, and soil pollutants that I mentioned. So of course, the path that the climate will take is uncertain. There are different scenarios and different ways of doing accounting. But we know that there are certain contributions to health damages, such as malaria, malnutrition, diarrheal disease, and these will have different contributions depending on the scenario. Added up, if you look at both the non-greenhouse gas emissions impacts, mostly dominated by particulate matter emissions, and the greenhouse gas emissions, we're talking about several 100,000 disability adjusted life years per year that are lost because of the healthcare system's impacts, the healthcare system's activities. So even though, of course, the focus is do no harm, we can see, in fact, that healthcare does have an attributable portion of healthcare damages, and this is an important realization. The last thing I want to note is that, of course, healthcare is a global industry like most other industries in our globalized world. And we can use similar models to track flows, the carbon and other emissions embodied in trade. And those are goods and services that are imported or exported by healthcare systems. This is the approach that we've taken in the Lancet Countdown. Myself and Dr. Sherman and others are working in this metric, indicator 3.6, around healthcare emissions. And we've been able to compare different countries. You can see here on the x-axis, different per capita healthcare greenhouse gas emissions by country. And this accounts for the trade that happens among countries. But it's important that we also consider the quality of healthcare that's being delivered. It's not really fair to compare greenhouse gas emissions when different countries have very different levels of healthcare services that are being delivered. So another version of the indicator 3.6 from 2 years ago in the Lancet Countdown report is comparing these per capita emissions against what's the Healthcare Access and Quality Index. And it shows a very similar pattern that you saw earlier for the Human Development Index, that there's a saturation effect. I'm based here in the US, and I'll give you a hint about what this circle over here on the far right is. What this tells us is that there are many healthcare systems that are achieving a high level of healthcare access and quality without such a high level of emissions. And this tells us that a low carbon emissions healthcare system is possible. So thank you very much for having me on the panel, and I'd like to turn it over to my fellow panelists.
Thank you, Dr. Eckelman. Again, for those of us who have joined us late, we will be taking questions at the end. Without further ado, I'd like to introduce Sarah Ouanhnon, who is Senior Net Zero Delivery Lead for the Greener NHS program team at NHS England and NHS Improvement. Within the team, she leads the delivery of the NHS net zero commitment across the supply chain, including medicines and food work streams and non-medicines. And she'll be speaking to us about the Greener NHS's program, sustainable strategy and carbon accounting of the healthcare supply chain. Without further ado, Sarah.
Hi, everyone. Can you hear me?
Yes, we can.
Great. Can I have the first slide, please? So as you've heard already, the NHS has been one of the first systems to commit to a net zero target. So it stepped up last year in October 2020 to commit to 2 net zero targets. The first one was a net zero target for its direct emissions by 2040. So it's the scope 1 and 2 emissions that you saw on Matt's graphic. And then the other target is to reduce all of our emissions, including in our supply chain, for 2045. So net zero by 2045. That was a year ago in October 2020. And I really wanted to start this presentation with some good news, which is we're on track. So despite COVID, despite the last 18 months, we are on track to deliver on this net zero target. And by the end of the financial year, we will have delivered a bit over 1,200 kiloton CO2 reduction. Another thing, so this reduction is always difficult to measure and to analyze. We know that it's mostly coming from the NHS staff direct actions, also the government, like national action, and also some of the impact of COVID, and both in a positive and in a negative way. Speaking of COVID, I wanted to share another good news, which is that in a recent survey, we found that 9 out of 10 of our NHS staff think that the NHS should make a priority of tackling climate change. So it's not just a national ambition, it's an ambition that's shared by everyone in the NHS staff. And that gives us really a lot to hope for in the coming years. Next slide, please. So the thing I wanted to focus on today is the net zero supply chain, because this panel conversation is about standardized metrics. And this is really one topic where we need those standardized metrics. Next slide, please. So you can see on this diagram, when we speak about the NHS supply chain, we speak about all of these blue area. So we speak about more than 60% of our carbon footprint. What is this made of? You can see a lot is made of medicines. So that's 20%. And there's an extra 5% at the point of use. And then medical and non-medical equipment, and other commission services. So you might know that the NHS commission services from other providers. So that's 60% of our overall carbon footprint. How do we plan to reduce this? Next slide, please. So this gives you an idea of how we plan to reduce these carbon emissions. Basically, when we speak about supply chain, we speak about demand and supply. So at the top of this waterfall chart, you see all these interventions which we expect will reduce carbon emissions by changing the way we consume goods and services. So an example that I'm sure you will all be quite familiar with is the moving away from single-use items, for example, to use reusable. And then we need to change the way also like supply works. So one way is to ask our suppliers to make their product more sustainable, so themselves move away from providing single use and then having more sustainable items. But then those two big green bars that you can see at the bottom of the chart is actually asking our suppliers to set as ambitious targets for themselves in terms of reaching net zero. And that's what those two bars at the bottom show, is that we will only reach net zero if our suppliers also reach that net zero at the same time. This can only be achieved with a partnership with our suppliers. And some of you might have heard yesterday, we had a panel conversation with some of our biggest suppliers in the UK pavilion. And you've seen that some of these suppliers are already leading the way. They're already very ambitious in their own net zero target. Next slide, please. So what will this partnership actually look like? It looked like a set of milestones, a set of asks that we, the NHS, make of our suppliers. You can see here a roadmap that we've recently shared publicly to show what we will require of our suppliers in the coming years between now and 2030. This shows that gradually we're including more and more requirements of our suppliers to be able to qualify for NHS contract. Initially, we start with scope 1 and 2 emissions, and then we increase to scope 1 to 3. Initially, we start with like big contract, like high value contract, and then slowly we expand to all of our contracts. And the idea is that we are asking our suppliers to disclose their carbon emissions and also disclose their plan to reduce their carbon emissions. To do that, we need to have frameworks. We need to have those metrics that we've been speaking about with Matt and Marina about how can suppliers disclose their carbon emission in a way that's meaningful and that we can then use. The other thing you might notice in 2028 is we plan to ask our suppliers to disclose information at product level. This is a bit more challenging because we really need to understand what we include in the scope of product level emission. And here again, we need to define frameworks to really make this information meaningful and usable in the future. Next slide, please. So this panel was not just about metrics, it was also about access and quality. And I thought I would flag that our first milestone in this roadmap is in next April, all of our tenders will include a 10% weighting on net zero and social value. And that's very important because in social value, there's not only net zero, but there's also equal opportunity. There's also like tackling economic inequality. And so we're also asking our suppliers to tell us what they will do to improve social value in each single contract they will deliver for us. And this picture was actually chosen really in purpose because when we speak about access, this is actually Sam, one of our supply chain manager in London. And you can see at that exact moment, she's getting a supply delivery from a boat in London. And so that reduces air pollution and at the same time improves access for vital supply like stents for patients. Next slide, please. And what do our suppliers think about all of this? So we've asked them, and actually most of them are either there. So some of them already have targets. Some of them already have targets aligned with our 2045 objective. And the majority of the ones who don't actually have a plan to have it in line with our expectations. So the feedback suggests that we're probably setting the bar at an ambitious, but also realistic level. The other thing we heard in the feedback is that not all suppliers are the same. There's a wide diversity. When you have 80,000 suppliers like the National Health Service in England, there is of course a diversity in our supply chain. And so what we've heard is also that we need to adapt to different types of suppliers. And that's why for our small and medium enterprise suppliers and also for our voluntary sector suppliers, we're giving a 2-year grace period on the roadmap you've seen in the previous slides. Next slide, please. So we've spoken about metrics. How do we measure progress? Next slide, please. Matt gave us like a really good overview of those input-output modeling, which are based on spend. That gives us a really good grasp on how we're doing at the top line and how we're going to do in the next few years. Now, the problem is, how do you reconcile this with the very specific interventions you're doing on the ground? So when we work on working aid refurbishment scheme, how do you link this very top line carbon reduction with actually how much carbon emissions you're reducing by refurbishing your working aids? And that's where really we need to be able to link this bottom-up approach, that's the sort of technical way of calling it, with this top-down approach to really be able to follow our progress and how we're doing. Next slide, please. So we're working on it. That's the key message. Like, we're adopting this continuous improvement approach. We're refining our indicators every year as we develop new interventions. And then we're also working with our suppliers to understand how we can measure change and how we can monitor progress within our supply chain. We're also looking at what's happening out there, and there are already organizations that are doing a fantastic job. So for example, this year, more than 200 of our suppliers declare their carbon emissions through CDP. And we are also looking at accreditation organizations like Science Based Target, EcoVadis, or B Corp. Next slide, please. Next slide. So I'm just going to finish with this. We've spoken a lot about supply chain, but again, this panel was not just about metrics, it was also about quality. And low carbon healthcare is good quality healthcare. So a key topic we're also working on is sustainable models of care. It's about providing the right care to the right patient at the right time and in the right care setting. It's about preventing rather than treating. And it's really important when we speak about reducing carbon emissions that we also look at this whole pathway of care. And at the moment, we're working with some of our national programs to define a carbon calculator that will help those programs consider carbon emissions when they define their new models of care. And, we're just at the beginning. At the moment, we're mostly considering activity. Is it in person? Is it remote? Is it in acute care setting? Is it in community health setting, in primary care? But the idea really is that this modeling approach will be more and more encompassing, so that really when we make decisions about how we deliver care, carbon can be a key criteria. Thank you.
Thank you, Sarah. Again, we will take questions at the end. Please feel free to start sharing them in the chat box. Without further ado, we'll move on to the final speaker of our panel, Dr. Andrea MacNeill. Dr. MacNeill is a surgeon at Vancouver General Hospital and a clinical associate professor at the University of British Columbia. She is the founder and principal investigator of the UBC Planetary Healthcare Lab, a novel interdisciplinary research collaborative dedicated to creating health systems that promote both human and planetary health. And she also serves as the medical director of the Planetary Health for Vancouver Coastal Health. Without further ado, Dr. MacNeill.
Thank you, Jodi. So my task today is to address the clinicians in the audience, and in a very short period of time, convey the tremendous opportunity that we have as agents of change for planetary health. There are 44 million healthcare workers worldwide, and we're seeing a collective awakening to the immediacy of the climate and ecological emergency. Sorry, my slides aren't advancing. There we go. Our paradigm shift begins with an expanded duty of care from the individual patient to the public and to the planet, a concept that's beautifully encapsulated in this Lancet call for an updated Hippocratic oath for the Anthropocene. The literature describes 3 levels of social accountability in clinical care, And we've adapted that here to create a ladder of engagement for clinician action around climate and ecological health. The micro level refers to actions that individual clinicians can take in their day-to-day scope of practice. Meso level actions occur at an institutional level, so usually a hospital or a health system, or within the local community that they serve. And then macro level actions are undertaken by governments, professional societies, and regulatory and oversight bodies that have the capacity for sweeping top-down mandates across the health sector. Clinicians can influence all of these levels by adopting an advocate role or assuming leadership and administrative responsibilities within their organizations or professions. Now, Jodi and I were co-authors on a framework for what we've termed planetary healthcare, which is our vision of low carbon, high quality, equitable healthcare delivery. And this was published in February in the Lancet Planetary Health, and it's represented by the infographic on the right. We then operationalized that framework for the individual clinician in the BMJ article that you see on the left, which was published in September. And you'll notice as I provide a few examples from this work today, that actions to mitigate the environmental footprint of healthcare almost invariably improve healthcare quality and equity. And the first thing to notice is that the framework includes both supply and demand side management strategies, because as you have heard from our previous speakers, we can't achieve net zero healthcare emissions with efficiency gains alone. We need an absolute reduction in the demand for health services, and that can only be accomplished by healthier populations. Healthcare only contributes to 20% of health and well-being. The remainder is the result of broader social, economic, ecological, and political determinants. So we need healthy public policies that modify these social determinants of health, such as is advanced by the WHO's Health in All Policies framework, that advocates for intersectoral decision-making that explicitly acknowledges the human health costs of policy decisions. Once you recognize that every healthcare activity has a footprint, you can readily appreciate that anything that reduces the incidence or severity of disease, thereby reducing the amount or intensity of care required, is a climate mitigation strategy. This requires robust public health and primary care structures to ensure universal access to preventive services and good chronic disease management. Our second operating principle of planetary healthcare is matching the supply of health services to demand, which means avoiding both overuse and underuse of healthcare. Underuse of necessary services like vaccinations or cancer screening leaves patients exposed to avoidable disease, whereas overuse of health services results in avoidable harms to patients, financial harms to health systems, and environmental harms. Inappropriate or low value care is characterized by care in which risks or harms outweigh the benefits, or care which will not influence clinical decision-making or change outcomes. Globally, about 25% of health services are low value, and in the US alone, this carries an annual price tag of $100 billion. Appropriateness of care is a neglected dimension of healthcare quality, and it stems from both system factors, such as healthcare structures and funding, and from clinician and patient behaviors. System factors include things like inadequate primary, community, or long-term care services, such that patients are forced to use acute care services for conditions that could be managed in less resource-intensive environments. So if we think through our ladder of engagement for appropriate care, we can appreciate how practices that we associate with quality care, such as adhering to evidence-based guidelines or critically appraising the literature to be able to generalize it properly to our patient populations, are in fact climate mitigation actions. Similarly, avoiding technology or indication creep, where something that's shown to be beneficial in one circumstance is uncritically applied to other clinical scenarios. Shared decision-making refers to a process in which providers help situate evidence within patients' own worldviews, incorporating their values and preferences. Studies of shared decision-making suggest that 20% of elective procedures would be unwanted if patients had access to understandable, relevant clinical information. At an institutional level, care coordination avoids unnecessary duplication of tests by allowing, for example, sharing access to electronic medical records across health systems. This improves patient safety and it leads to better patient experiences. Electronic medical records can also encourage resource stewardship by applying stop dates, for example, to antibiotic orders or laboratory investigations. There's a documented human tendency to add choice and complexity, but never take away. But de-adoption of low-value practices is an important aspect of appropriate care. Some hospitals have removed from formulary the inhaled anesthetic desflurane, for example, due to its outsized climate impact. And at a macro level, the most important driver of appropriate care is universal access. I'm still processing the knowledge that uninsured patients in the US can't access primary care services to manage their chronic conditions, but they are covered for hospital-based care once they suffer a catastrophic health event. This is a glaring supply and demand mismatch, and it's absolutely terrible for health outcomes. Codifying evidence-based best practices in clinical practice guidelines increases uptake, standardizes practice, and confers a degree of medical legal protection. The third operating principle of reducing emissions from the supply of health services captures the classical notions of sustainable healthcare, such as decarbonizing building energy supplies and electrifying transport fleets. And these things are important, but typically outside of the purview of the clinician. What is more within our scope are decisions around mode of care delivery, such as appropriate use of virtual care platforms. These not only eliminate patient travel miles and resource-intensive interactions with the system, but they're an important component of health equity in ensuring access to specialist care across geographies. When appropriately applied, virtual care has been shown to be more convenient and cost-effective for both patients and providers, both of which are dimensions of healthcare quality. Now, as you've heard, the majority of healthcare emissions arise from the supply chain, and this is largely the result of our current healthcare supply chains being reliant on single-use disposable devices. Single-use devices are an example of a linear economy in which products are manufactured, used once, and discarded. And the solution I would propose is a so-called circular economy in which materials are kept in circulation at their highest value application for as long as possible. This includes an emphasis on reduction, followed by a series of strategies from reuse to repurposing to eventual recycling. Multiple studies of single-use versus reusable products have shown several-fold higher petrochemical use, emissions, and solid waste with disposables. The circularity in healthcare requires thinking across silos, such as the notion of repurposing surgical gowns as non-sterile PPE once they're no longer fit for the high-level barrier protection required for surgery. A circular economy approach has also been shown to be more cost-effective, such as in this study that Jodi and Matt did, comparing reusable and disposable laryngeal mask airways. Not only did they show that reusables outperform disposables across every environmental impact category, but they also saved Yale-New Haven Hospital $1 million a year. At an individual level, clinicians can address our disproportionate supply chain impacts by focusing on conservation of material resources. So not taking a whole stack of supplies into an isolation room, for example. We can select environmentally preferable options where choice and data exist, such as avoiding desflurane or using dry powdered inhalers instead of metered dose inhalers. And we can engage with industry to drive innovation towards circularity. Hospitals need progressive procurement policies that favor reusables, and as Sarah just described from the NHS, that mandate ambitious environmental commitments from manufacturers. Infection control practices must be evidence-based, as this is a primary driver of unnecessary single-use consumption. And institutions can apply rules and restrictions around the appropriate use of single-use consumables. At a macro level, embedding low-carbon best practices in clinical practice guidelines will be higher yield than educating for individual behavior change. Governments and regulators can introduce policies that mandate responsible resource use by both vendors and purchasers, such as Sarah just described. And healthcare structures like hospital accreditation and quality improvement frameworks can be updated to explicitly account for environmental impacts of care and recognize these as elements of patient safety and quality. So we began with an expanded duty of care, and we finished with an expanded notion of patient safety, quality, and equity. Practicing planetary healthcare is in no way additional to other paradigms of good clinical care, but rather it's synergistic with all of these in our collective pursuit of intergenerational health and well-being. Thank you.
Thank you, Dr. MacNeill, and thank you to all our panelists. We do have some questions in the chat. I ask you to place your questions in the chat, and if we get through these, there may be opportunity for you to raise your hands and also offer questions if that's a preference. Let's start with, there are several along the theme of low middle income countries. And so as much as is possible, it would be nice if each of our panelists might comment on how their presentation, their work is felt by, affected by, limited by the current state of healthcare delivery in low middle income countries. Dr. Romanello, if we could start with you, that'd be great.
Yeah, absolutely. One of the things that particularly in this year's report we have really seen is that those countries that are already very vulnerable, those which have the lowest level of what we call the Human Development Index, which takes into account metrics of health and health delivery, are the ones that are being the most impacted by climate change risks, and particularly those that are being the slowest to perhaps adapt or deliver that institutional health adaptation response to climate risks. But at the same time, they're also the ones that are perhaps lagging behind in being able to decarbonize, to transition towards lower carbon economies, and to make the most out of the health co-benefits that come with that transition. So one thing that is really interesting and has really seeped through our data this year is that because of the excessive impacts on the most vulnerable populations, and because of that delayed response, it has become so much more important, so much more urgent that the least developed countries, the lower Human Development Index countries, are getting the support and are accelerating action to protect their people from climate hazards. Obviously, the health system, healthcare delivery is fundamental in delivering this, but the whole of the policy system needs to be adapting and responding to climate change hazards. One of the key issues here, one of the key items, is that in delivering that response, health needs to be considered at the center of all policies, whether it's a policy of infrastructure, of green space in urban areas, of decarbonization. Is really critical that the health system has a voice, has a say, and interacts really closely with the environmental departments and the urban planning departments to ensure that in all of those policies, climate change is protected and health is maximized. So there's a key role there for the health professional that goes a bit beyond what the kind of hospital or health setting per se might be, and can deliver enormous dividends for health of people.
Thank you, Dr. Romanello. I actually think that ties in very closely with what Dr. MacNeill was telling us. And perhaps, Dr. MacNeill, you could offer some further thoughts.
Yeah, thank you. I think that we can look to low and middle income countries for models of more efficient resource use. So I was quite struck by Matt's slide showing the degree to which the US is an outlier in terms of its health expenditures versus its health outcomes, and how it achieves potentially equivalent, in many cases, inferior health outcomes with many more times the expenditure than countries with lower health expenditures. So I think we can look to low and middle income countries for examples of more efficient resource use. They certainly, in many cases, have not bought into the myth of the need for a single-use dominated supply chain, but rather have demonstrated the safety and efficiency and resilience of a circular economy-based supply chain. It was interesting to see some high-income health systems, in particular in the US, operate under resource constraints for the first time during COVID, when supply shortages kind of imposed restrictions that those systems had never previously experienced. And this helped shape a little bit of a paradigm shift that I hope that will persist beyond the pandemic, so that we all recognize that we live on a planet of finite resources and need to operate as though we are resource constrained at all times.
Thank you, Dr. MacNeill. Dr. Eckelman, understanding that there are challenges in data, and this could sort of tie in between low middle income data that we have, and what does, ideal data look like? Perhaps you can tie those 2 points together for us.
Sure, thank you. So carbon accounting frameworks have lots of different forms. I showed some examples of top-down accounting frameworks used for carbon and pollutant emissions accounting. You saw a really great example in the NHS of a hybrid accounting method where they have both some bottom-up information and also some top-down estimates using this blend of data. And it's true that not all countries have the public health infrastructure or statistical infrastructure to do every kind of carbon accounting, including the top-down estimates that I showed earlier. But the important thing is to adapt some kind of carbon emissions accounting framework. And there are great examples of organizations rolling out carbon calculators and decarbonization planning frameworks to help healthcare systems in low and middle income countries to get started and to work in this area of carbon emissions accounting, both at the government level and also at the facility level. It's a flexible enough framework that even just getting started on scope 1 and scope 2 is possible given information that's readily available in pretty much any setting.
Thank you, Dr. Eckelman. Sarah, there's actually a lot of excitement and interest around the procurement policies that the NHS is developing, and tying that in again to these questions of low middle income countries. But in general, might you say, how might other nations participate in, model after, leverage our collective purchasing power together? What opportunity is there already for us to collaborate, and what further things would you like to see in terms of the international community coming together on this?
Thank you, Jodi. Yeah, it is a global challenge, and it's probably like we need a global solution. So when we set requirements of our suppliers, they are global supplier, like a lot of them are multinational companies, and it's very important that we collaborate with all other countries so that we make it feasible for suppliers. So you don't want the NHS to say, well, this is what we require from our suppliers in this framework, and then having other countries trying to do something completely different on a different timeline. So we're, in that sense, we're really, really open to collaborating, to share our work and how we got to the timeline we got to, the metrics we have. We are also doing some more specific work. So for example, a month ago, we worked with an organization in England called Prescript to survey manufacturers of inhalers to ask them about the life cycle carbon emissions of inhalers. And this is something that is now publicly available on the Prescript website. So we are really, really keen to share this information and to push our suppliers to be as transparent as possible. And this is why when we require information from them, it's not just for them to give it to us, the NHS, but it's to make a public commitment in a carbon reduction plan that can also benefit other countries.
Thank you, Sarah. Dr. MacNeill, would you care to delve in a little bit deeper on barriers to achieving the circular economy and how clinicians can help overcome these?
Sure. I think the number one barrier is the perception, or more accurately, misperception of improved safety with single-use devices. So this is a myth that has been very successfully propagated to a clinical audience and taken up by regulators and oversight bodies alike, such that there are now really deeply entrenched systemic factors that are driving single-use uptake, such as a preference for that by hospital creditors, for example, or ways in which the FDA makes it easier for manufacturers to bring to market single-use devices rather than reusables. So we need to tackle that at multiple levels. We do need clinicians to engage in advocate roles with the regulatory and oversight bodies, and individual clinicians to engage with their hospital leadership, and in particular with their hospital infection prevention and control partners, whom I would suggest are our most strategic allies in eventually arriving at evidence-based infection prevention practices that demonstrate the safety of reusables. The other part of the the safety conversation is that perception of improved convenience with single-use items and of lower cost, both of which are only true if looked at through a very, very narrow lens. So single-use reliance allows hospitals to divest of infrastructure for inventory and reprocessing, and that may be more convenient under business as usual scenarios. But as we saw to a tragic extent during COVID, that system is susceptible to catastrophic disruption. And ultimately, PPE shortages led to the deaths of hundreds of healthcare workers because of that sort of reliance on single-use devices. Similarly, the perception of lower cost is only applicable over a very short time horizon. When you factor in the many more life cycles of reusables and avoided disposal costs and avoided environmental costs, they invariably come out as more cost-effective in all of the published studies to date. So we need clinicians to be undertaking those studies, to be engaging in quality improvement projects, and to be exercising their personal choice to drive demand for reusables in their individual hospital supply chains and then up throughout industry.
Thank you, Dr. MacNeill. Dr. Eckelman, I think this taps into more of your background in chemical engineering in addition to the environmental engineering metrics you just presented, but can you comment on how the pharmaceutical industry can work to make health systems more sustainable, make medicines more sustainable, and also how we might actually measure that?
Sure, thank you, Jodi. So the pharmaceuticals and medicines were one of the largest contributors in the supply chain to healthcare system emissions. And this has to do with intensity, the energy intensity and carbon intensity of fine chemicals and pharmaceuticals manufacturing. It also has to do with the sheer quantity of drugs that are purchased and used. So the pharmaceutical industry itself has a history of collaboration, thinking about sustainability and thinking about efficiency. And this is an area where the allied field of green chemistry has really brought pharmaceutical manufacturers together to focus on improving yield, to focus on reducing the use of hazardous chemicals during processing, and to focus on improving the carbon emissions profile of manufacturing. And you see some very large pharmaceutical firms setting ambitious targets for their own carbon emissions reductions. So I was very glad to see the partnerships that Sarah talked about that NHS is taking, including with pharmaceutical suppliers. And they're a really important linchpin in this overall decarbonization effort.
Thank you, Dr. Eckelman. I think we have time for just one more question. I'd like to pose that to Dr. Romanello. How do you see the work of the Lancet countdown expanding globally and how that can aid healthcare's response, since that's the subject of this panel? Thank you.
Thank you, Jodi. One of the, I think, most crucial elements to what the Lancet countdown does, what the tracking mechanisms do, is that it provides a view of how climate change is already affecting health and almost real-time through its annual reporting mechanism to monitor how the transition to a lower carbon economy, lower carbon systems can provide benefits to health through those kind of health co-benefits and directly avoiding the impacts of climate change. It's very worth taking into account that there's many countries, there's many organizations that are producing metrics on climate change and health that are starting to monitor particularly kind of the health impacts of heat, of air pollution, and some of the key co-benefits. But these are some very, very few countries. The European Environment Agency has just set an observatory on climate change and health, for example. There's a few countries that are setting up their own observatories as well. But these metrics generally are not standardized. So what we are trying to know, what we're trying to provide is some benchmarking mechanism that will allow the world to monitor progress and keep ourselves accountable. One of the key elements of what we're trying to do at the moment is actually expanding our Lancet Countdown network and developing some regional and national centers that will start to produce data and monitoring mechanisms at much more geographical, high result level, and using as far as possible official metrics from health systems such that health professionals can also take this on board and compare with their own benchmarking mechanisms. But it's really important that beyond what we do from the Lancet Countdown, countries start collecting this data and start monitoring climate change as it pertains to health, and what the opportunities look like and how efficient all of these climate change mitigating activities are in delivering benefits to health, because that will help us actually track and monitor and quantify that increased health benefits, that additional benefit of climate action that should be included in all of the policy considerations and all of the cost benefits assessment for any type of policy. The health elements will be crucial to it. So we try to provide that at a global level, and we're trying to refine and provide much more locally relevant metrics. It's also crucially important that countries do start monitoring this and also help us build those indicators moving forward.
Thank you, Dr. Romanello, and that is the final word. This concludes our panel session today, and I'd like to thank all of our participants and our panelists, and we will be posting this for future viewing. Thank you very much.